Yes, Shalini.
Are we live, ma'am?
Yes, we are live.
Okay, sure. I will start with the program.
Yeah.
A very good evening and a warm welcome to all. We welcome you to the CME on Fetal Ultrasound ISUOG Basic Training 6-Step Approach. And for today's program, the digital partner is Clarinet. I would like to play a short Clarinet's video and would request everyone to please have a patient look. Thank you very much for the patience. Now I would like to request Dr. Ritu Sanfani ma'am to take over the session from here. First, I would like to introduce her. She is an MBBS, MD, FICOG, FIAOG, AMRCOG. She is the director at Pune Test Tube Baby Center and Sham Well Women Clinic. She is also an obstetrician and gynecologist, cosmetologist, and IVF specialist. Ma'am, over to you.
Yes, yes. Thank you, Shalini, and thank you, Clarinet team, and a very, very warm welcome to our special international expert today, Dr. Solmaz. So, friends, I hope all of you agree with me that knowledge sharing is the best thing in this digital era, and knowledge has no boundaries. So, for that, I have invited today a very, very dear friend of mine, Dr. Solmaz Piri, who is ICOG ambassador for the for the Africa zone. So a very, very warm welcome. I will just start sharing my screen. So my all the webinars and all my activities will start with Durga Mata Stuti. So as always, so Ya Devi Sarvabhuteshu Chikitsa Rupen Sansita Namastasye 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 Namo Namah. So the guest of today is Dr. Solmaz Piri, obstetrician and gynecologist, fellowship in fetal medicine from KCL and MFF London, director of international affairs of National Association of Iranian Gynecologists and Obstetrician. She is ambassador of ICOG in Middle East and North Africa. And madam is very, very humble. I am so honored and pleased to welcome you, ma'am, here. So madam is a member. Madam is a member of several national committees, including the Ultrasound Committee of NIGO and Medical Disciplinary Committee of the Medical Council of Islam Republic of Iran and Guideline Committee for Endocrinology in Pregnancy and the Committee of Screening for Down Syndrome. Madam has won the National Association of Iranian Gynecologists and Obstetricians Award for Exemplary Practice Award in 2016 and she is a virtual mentor for ICOG 2019. And she has been elected as an ambassador of ICOG in Middle East and North Africa in February 2021. So a very, very warm welcome. Salam to you, ma'am. And to all our delegates who have joined all across the geography, Chitori and Khushamuddin. So before I hand over dais to ma'am, there are some announcements I have to do. So friends, as all of you, madam is going to discuss with us with this ICOG basic training 6 steps approach. So there are few announcements before I hand over session to the Dr. Solmas. So friends, as you all know, this September month is the PCOS awareness month. So tomorrow join me around 3 p.m. Indian Standard Time. Going to discuss with a very, very important topic, the PCOS and nutrition. So sharp 3 p.m. tomorrow we are going to start this session. Besides that, there are a lot of queries I am getting for this master class. So there are 3 online master classes we have already planned for this: infertility, aesthetic gynecology, sexual medicine, and cosmetology. So 19 we are having cosmetology. This is already full. And for 8th and 9th October, we are having this master class for this sexual medicine. Again, this is certified by ASFMS and NAM. So all of you, those who are interested to know more about the sexual medicine, I think this is very, very important for each of the gynecologists. We are getting a lot of patients related to this. So these are the some informations related to that. So now I'm handing over the session to. So now I'm handing over the session to Dr. Solmas. Dr. Solmas, a very, very dear friend, and we are really honored, ma'am, to have you with us. And thank you once again for accepting the invitation.
Hello, and thank you very much, Dr. Ritu, for your very, very kind introduction and very kind invitation. And it's actually an honor and a pleasure to collaborate in this program, and I hope your audience find it useful.
Sure, ma'am, sure.
So, okay, so I think I just start sharing my
yes,
screen.
Yeah.
Okay. All right, so I start, as you said, my talk is going to be about ISUOG basic training and the 6-step approach. I asked actually Professor Bilardo, who I'm sure many of you know her, and she has been the elect president of ISUOG, to let me use some of her slides who are available from ISUOG website and also from the internet for free download, just to emphasize the views of the society on how we should approach the ultrasound scan. So, you know, obstetric ultrasound scan is a difficult procedure per se. The reasons are it's an operator-dependent modality. We encounter with complex fetal organ anatomy. The fetal movements make the process even more complicated, and there are always shadowings of target anatomical regions by overlying structures. And also, it becomes more complicated by maternal body habitus. For simplification and standardization purposes, so some modalities like 6-step approach have been introduced. And they are useful because they enhance training from different ways. They can minimize ultrasound steps. They introduce consistency in image acquisition and interpretation. They allow for efficient examination, they shorten the learning curve, and they also provide path for automation. The standardized 6-step approach to performance of the focused basic ultrasound examination was first introduced by Professor Alfred Abu Hamad and his colleagues, and they published a very important paper in American Journal of Perinatology about it in 2016. And because it worked very well, they showed the data very clearly how it contributes to a better scan quality. The ISUOG Education Committee now recommends to use this six-step approach in any ultrasound, in any obstetric ultrasound scan. Before entering this six-step approach in detail, I would just like to share my own experience with you. When I started learning ultrasound scan in Fetal Medicine Foundation in London, all my seniors actually, before starting me, reminded me that I need to pay attention to 3 basic points. Number 1 is orientation. And what does orientation mean? It means left and right. I'd like to emphasize that you need to distinguish the left and right of the fetus the same way that you distinguish the left hand and right hand of yourself. So you shouldn't decide if one hand is left because the stomach is there. Because, you know, the stomach is not a fixed organ. In some abnormality, it might be right-sided. So you need to always imagine how the baby is lying in the uterus. Where is the head? Where is the buttock? And what's the left and what's the right? And this means the orientation. Number 2 is magnification. When you are looking at some particular structure, you have to magnify it in some way that more than 50%, and in most cases about 75% of your monitor is occupied by that. And number 3 is gain. Gain means the whiteness of your image. And if the image is too white, you lose details. So we recommend that you put the gain as low as possible. These are the different movements of the probe during an ultrasound scan. So if you place the probe perpendicularly on maternal tummy, and if you move it in parallel planes, this kind of movement is named sliding. If you put the probe perpendicularly again and you rotate it, so you look at one structure in some planes that cross each other, this is called rotation. If you put the probe on the perpendicular plane and then you just tilt it from this 90-degree plane to some other degrees, it is called angling. And if you just press one side of the probe deeper on the mother tummy, then you make your probe nearer to some specific point in the same plane. This kind of movement is called dipping. So now we enter the six-step approach. Let's start systematically. So step 1 is to determine fetal presentation and lie. So I'm sure all of us, you know what the definition of lie and presentation is. Lie means the angle of the fetal spine to maternal spine. And presentation is the particular part of the fetus which is lying in the lower uterine segment. So to determine the presentation and lie, you put the probe in a perpendicular plane in transverse section at the lowermost part of the maternal tummy, just above the symphysis pubis, and you look at what you see. So you get one of these 3 images. If you see the head of the baby, the presentation is cephalic. If you see the buttocks, the presentation is breech. And if you don't see anything, it means if you see just a pocket of fluid, it means that the baby is lying either in a transverse or oblique position. Step 2 is to determine fetal cardiac activity. Obviously, it is very important to determine if the fetus is alive. So in order to find the cardiac activity, again, you put the probe in the lowermost part of the maternal tummy and you move it toward the umbilicus. If you still don't find the heartbeat, you go towards the left and right to find the heartbeat. Again, this is a depiction of the step 2 of six-step approach. Step 3 is to determine the number of the fetuses. The number of the fetuses is determined by the number of the heads that you see inside the uterus. And in order to find out how many heads you see inside the uterus, obviously you have to scan the whole uterus. Again, you start from the lowermost of the maternal tummy and you move your probe using a sliding movement to the fundus, towards the fundus. You repeat this in parallel lines, and again you do the same movements in transverse planes. This helps a beginner to find out exactly how many heads are there inside the uterus. The important point is not to angle the probe. You have to maintain the perpendicular position of the probe all the time to determine the number of the fetuses, because a naive sonographer might mistakenly look from two angles to the same head and might mistakenly think that this is a twin pregnancy while it's only a singleton. Step 4, which is of utmost importance, is to determine the location and position of the placenta. As all of you know, I'm sure know, determining placenta previa and placenta accreta are some very life-saving diagnoses. In order to determine the location and position of the placenta, we put the probe in a sagittal plane, again perpendicularly on maternal tummy. We start from the fundus. First, we visualize the fundus, and then we go downwards toward the lower segment. And we repeat this movement to see where the placenta is lying. Again, we might get one of the three images. When we put the probe in fundus, if we see the placenta lying there, it is most probably a fundal placenta. But this is not enough. We have to follow the edges of the placenta to make sure that it finishes at some point between the fundus and the cervix. If we go down and we see that the placenta is lying down in the lower segment of the uterine cavity, we have to visualize the cervix and the position of the internal os. As you can see in the middle image, the lowermost edge of the placenta is lying adjacent to the internal cervical os. So this is a marginal placenta, and the cold insertion is actually at the same place too. If the placenta is actually lying high and apart from the cervical os, we call it usually a high anterior or high posterior placenta. Determining the position of the placentas in a posteriorly positioned placenta might be more difficult and more challenging because of fetal shadowing. And if we suspect a placenta previa or marginal placenta, it is always wise to go transvaginally and to determine the exact position of the placenta to perform a good planning for delivery. Again, this is a depiction of how we find out the position of the placenta. Step 5 is estimation of amniotic fluid. For simplification and clarification purposes, there are two methods of determining the amount of amniotic fluid. One is AFI, which is we just measure 4 pockets of amniotic fluid in 4 quadrants. But for simplification purposes, Professor Abu Hamad actually in his book suggests to look for MVP. I will go to the pictures and show you what does it mean. But because this image shows how we do that, you can see that the maternal tummy is divided into 4 quadrants. Again, we place probe perpendicularly in a parasagittal position on these 4 quadrants and look for the deepest pocket of amniotic fluid. We should avoid angling the probe like this and to wrongly look at the pocket of fluid in a transverse position, because this will make some overestimated views of amniotic fluid. So we make 4 quadrants and we look for the deepest pool. If the deepest pool is more than 8 centimeters, it complies with the definition of polyhydramnios. So this patient is a polyhydramniotic pregnancy. Again, emphasizing on the perpendicular position of the fluid to find the maximal vertical pocket of amniotic fluid. And if the length of maximal vertical pocket of amniotic fluid is below 2 centimeters, it complies with the definition of oligohydramnios. Again, both conditions are significantly associated, can be significantly associated both with fetal and maternal mortality and morbidity, and we should pay very good attention to these conditions. Step 6 is to determine fetal biometric measurements. The most important biometric measurements are biparietal diameter or BPD, head circumference or HC, abdominal circumference or AC, and femur length. This is an image of trainees practicing 6-step approach on the patients. As you know, ISUOG is doing outreach programs where the beginning of ultrasound training is with this 6-step approach that we're speaking about. Professor Abu Hamad and his colleagues in their paper showed very clearly and nicely that following these steps is very much time consuming and very effective. So trainees, after doing like their logbook, like 100 exams, they can reach some efficiency that they can do the 6S approach in some minutes, which is very, very important and very useful. This is the book of Professor Abu Hamad, which is free to download from the link provided in this slide, and also there are links in ISUOG website, and it's also translated to different languages. I would highly recommend to download the book, to read it. It is very useful, and it is written by well-known authors. So the key points up to here is ultrasound examination in the 3rd and 2nd trimester of pregnancy should be approached systematically. The sequence is fetal presentation, heartbeat, number of fetuses, placental position, amniotic fluid estimation, and biometry. And a standardization enhances trainees' confidence. 6-step approach is primarily intended especially for outreach settings because they are easy to learn, they don't require sophisticated equipment, and they can identify high-risk pregnancy. Another very, very much important issue is pregnancy dating. So especially for Dr. Ritu and her colleagues who practice IVF pregnancy, the most precise way of dating a pregnancy is embryo transfer date in ART or IVF. In other pregnancies, non-IVF, I mean, we usually use CRL, especially between 8 to 14 weeks. If a mother has missed this period and comes to us after 14 weeks, the best way to date the pregnancy is head circumference with or without female length, especially between 14 to 24 weeks. And after assigning the gestational age, the biometry is used only to assess the size, not to change the gestational age. In many countries, I'm aware, especially in some low resource settings, mothers get some ultrasound scans and they come to us and they are very worried, they're stressed, and they ask, okay, my baby was 28 weeks a month ago, now it's only after a month, I expect it to be 32 weeks, but the sonographer tells me it is 30 weeks. This is not a correct and academic way of explaining what has happened. As I told you, after 24 weeks, we don't change the gestational age. We just assess the size. So we can tell the mother that the gestational age is 32 weeks, but the baby has not grown as expected, and explain the details. So as I told you, if in non-IVF pregnancies, the best way of gestational age determination is using CRL between 8 to 14 weeks. But what CRL is correct? A CRL should be measured in a neutral position. And what's the definition of neutral position? As you can see, there are 3 pictures here, and the right-hand side image is the correct CRL. So in neutral position, there is some fluid between the chin and the chest. If we measure the baby in a hyperextended position, especially in this early gestational age, we overestimate the gestational age, and if the baby is too flexed, you see there is no fluid between the chin and the chest, then we underestimate the gestational age. In ISUOG practice guidelines, when you look at the biometry part, you can find the details, what are the correct planes, and where to measure the different parameters. You can find it in a table. I don't go through the table, I just go to some images for practical purposes. I would like to emphasize that we usually estimate the fetal weight by Hadlock 3 formula. Number 3 means that we use 3 parameters. We use abdominal circumference, female length, and HC when we use Hadlock 3 formula. And if you pay attention to the formula that I have brought here, you can see that the coefficient of abdominal circumference is 4 times that of femur length or HC. So that's why the abdominal circumference is the most sensitive parameter in determining the appropriateness of fetal growth. This is the plane where we measure HC. We can measure HC both by measuring 2 diameters of the head, BPD and OFD, and also by using the ellipse. Both are correct. Again, according to ISUOG guidelines, we can either use transthalamic or transventricular plane for measuring head circumference. I personally prefer transventricular plane. It is a bit more difficult, but you also look at the ventricle and you determine if there's a ventriculomegaly. So every plane in geometry is defined by 3 landmarks. So when you look at a specific plane to start with fetal biometry, every time you have to ask yourself, where are your landmarks? Our landmarks in HC are cavum septum pellucidum, these 2 parallel lines in front of the head. Posterior hormone. Sorry. Okay, I think one of the audience's speaker is open. Okay. Also, we look at the posterior horn of the lateral ventricle, and we look at the falx cerebri. The image should be symmetric, and this is what we can get most of the time. And we measure the BPD from outer to outer edge of the head, and OFD the same. In older books, sometimes you see that there are some definitions that BPD is from outer to inner border of the skull, but this is not accepted today. It is exactly like measuring the head circumference of a neonate. So you see, you take the tape and you put it around the head of the baby. So it has to be from outer to outer edge. In BPD section, as I showed you, we don't see cerebellum. If you see cerebellum, this is called the transcerebellar plane, and this is not a plane where we measure BPD. But I just put this here, just show you the cerebellum and show you some anatomy inside the brain. The middle image is the correct plane where we have to measure BPD and OFD and the head circumference in general. All 6 images around are not correct planes. So we use the different types of probe movement to get the middle image, and then we do our measurements. This is a histologic depiction of brain of the fetus, which you can see correlates very well with ultrasound image. And this is measuring head circumference by ellipse. This is a mother with a high BMI. As you can see, the image is not as clear as what I showed you before, but still you can find the landmarks. So this is fundamental. Don't forget the landmarks. Sometimes you look for the landmarks, but you don't get them. And you ask yourself, are you wrong? Are you right? What I can say is trust yourself. If you don't find a landmark, you have to refer that patient. So in right-hand side image, you can see that you don't see the cavum septum pellucidum. And that's right, because cavum is not there. And this is a case of agenesis of corpus callosum. In the left-hand side image, you can see that the head shape is like a lemon. And also you can see that the posterior horn of the lateral ventricle is dilated. And if you go to cerebellum, you can see it's not a normal heart-shaped cerebellum. It is more like a banana. And this is a case of spina bifida. Both of these cases, if any sonographer encounters, I mean, we expect even a beginner who has completed her logbook and is doing biometry and is doing 6-step approach, if he or she comes across such planes in BPD, they understand that there is something wrong with the head of the baby and this patient needs to be referred. This is the female length. Again, according to ISUOG guidelines, we have to visualize both ends of the bone and we have to put the bone in a position which is at an angle less than 45 degrees to the horizontal line. And then we measure the FL. This is the humerus. Humerus has exactly the same shape as the femur. And it is not uncommon for beginners to mistake this bone for femur. It is very important to look at the anatomy, to look at the position, and to measure the correct bone. This is AC, the most sensitive parameter by help of which we can determine if a baby is SGA or IUGR. The dotted yellow line is the correct cross-section and the correct plane where we have to measure AC. And what are the landmarks of this plane? The first landmark is the stomach, which has to be on the left side of the baby. Again, as I told you, in the beginning of the scan, you have determined what your orientation is, and you determine if the stomach is in the left-sided position. The second landmark is the middle third of the umbilical vein, and the third landmark is the spine. We have also to include only one rib in this cross-section. And just sincerely, I would have told you it's more than 12 years now that I'm doing fetal scans, and it's always possible. Sometimes it's difficult to get this kind of image, but it is always possible with giving enough time. The upper left image, as you can see, you can't see the stomach, you see the kidneys, and also you see the upper third of umbilical vein. This is a lower cross-section through the dotted red line, and this is not the correct plane to measure abdominal circumference. Again, this is an image of abdominal circumference in a high BMI lady. As you can see, although the quality of image is low, but you can identify the landmarks and you can do proper measurements. This is a lady. We tried to visualize the stomach and we got this image. You can see there are two stomach-like bubbles. This is a case of, this is a sign actually called double bubble sign, and this is a stomach outlet atresia. This is another lady. We tried to visualize the stomach, and the stomach was very faintly visible here, very small. This was a case of esophageal atresia. So both cases, we expect every sonographer to detect this kind of cases and to refer them appropriately. Sometimes we come across head circumference and female length discrepancy. So what should we do? We have to review, we have to remeasure. And if we make sure that they are discrepant, we have to consider referral to rule out conditions like chromosomal abnormalities, IUGR, skeletal dysplasias, and microcephaly and spina bifida. If the placenta covers the internal os, obviously it is a placenta previa, or if the lower border of the placenta is within 2 centimeters of internal os, it could be a low-lying placenta, and we have to repeat the scan at 32 weeks to determine if it goes up or not. And I would like to thank you very much for your attention. And I'm also happy to receive any questions.
Thank you so much, Dr. Solmaz, for a very excellent presentation.
Thank you.
Yeah. You have to stop sharing of your screen.
Yeah.
So around 100 doctors have joined along with us in at present. So thank you once again. A very nice presentation. So
thank you.
So this session has gone live too on my YouTube channel. So those who have missed initially can go and subscribe my YouTube channel, and you are able to see all the recordings, and so many other educational videos are also there in my YouTube channel. So if any queries, all of you can write here. So meanwhile, we are getting a lot of appreciations, Dr. Solmaz. You can see in the chat box, there are a lot of, lot of doctors are requesting for more webinars. Huh? So there are a lot of...
Thank you. Sure. So it's a pleasure.
So nice of you.
Thank you.
So now the doctors are not writing any questions, so I am having some questions. So meanwhile, I will start with the questions. Dr. Solmaz, as you are expert in this field, we want to know some tips when we are doing the sonography of the obese patient. Sometimes it is very difficult to take the parameters in that patient. So any practical tips you want to guide us?
First of all, actually, I think it's to practice under observation, if possible.
Yeah.
I've taken part in ISUOG outreach program in Oman, and I've traveled with actually ISUOG team, and I think this is the best way, and it's amazing how the trainees do on the observation. So I think it's very, very important. In the beginning, when you start scanning, you're lost. You understand what I'm speaking about. Every day you have to learn something new. So you have to start with orientation, as I told you. Left and right of your probe, left and right of yourself, left and right of the patient, and left and right of the fetus. And, it is sincerely, I mean, if trainees are really interested and they follow the rules, they master it, and they take the learning curve, it requires that you just have these basic points in mind, and you practice them at least on 100 patients. After 100 patients, you will master this 6-step approach. Obviously, it will need patience. And it is different to what a general obstetrician does in her everyday practice. So people who are interested, they need to pay attention, they need to be patient, but they will reach that point. And as I told you, after 100 cases, as I showed you in a very nice paper of Professor Abu Hamad, they will be able to do it within minutes. And it takes such a huge, I think you would confirm, it just does such a huge contribution to women's health. And you can do it with, I'm really sorry that I don't have the picture of the very first ultrasound machine that I started learning with. The size of the probe was like a brick. It was that big. But today, we are in an era that little by little people are start doing ultrasound with their mobile phones. So it's a really long way to go, but it was still possible. Even that brick type probe helped us save lives.
C'est pas. So, Dr. Piri, thank you so much. Another my query is related to that. What's your opinion regarding the role of 3D and 4D USG in the first trimester?
You know, this the ultrasound diagnosis is moving towards first trimester, and we know a lot nowadays about fetal brain, about in first trimester of pregnancy. In my opinion, it has a very good role in fetal brain in first trimester. But you know, it needs really sophisticated machine. It really helps, because even nowadays we can detect posterior fossa abnormalities in first trimester. I think it was like 10 years ago, it was like a dream, but this dream comes true nowadays. So, but it is not normal 3D or 4D like, you know, this 3D images. It is some other modalities like VCI and TUI and those kind of imaging with help of 3D ultrasound that helps us with prenatal diagnosis.
Thank you.
In first trimester.
Yeah. Thank you so much. Now I received one question. Let me see in the question answer box.
Yeah, I think one of the colleagues actually asks about twin pregnancy and how can we determine monochorionic or dichorionic placenta. Yeah, thank you very much. This is a very good question. After we determine the number of the fetuses, obviously, the most important point is to determine the chorionicity, because chorionicity is what makes the prognosis clear. So we look at if there is two heads. If there are two heads, we look at how many placentas are there. Sometimes placentas are quite placed in different, you know, one is anterior, while the other one is posterior, so it's quite clear that there are two placentas. But sometimes they are adjacent, and it is a bit difficult to know if it is monochorionic or dichorionic. In such a point, we have to pay attention to the dividing membrane. The dividing membrane in monochorionic placentas has a T sign. So you see the surface of the placenta, and this dividing membrane comes directly from the surface of the placenta. I'm sorry that I didn't include any images, but if you go online and if you look at your patients or even at Google Images and you Google monochorionic pregnancy dividing membrane ultrasound, it will bring you nice pictures. So it shows you T sign. But in dichorionic placentas with adjacent placentas, actually, it shows you lambda sign. So there is a ridge of placenta coming in between two membranes. And the membrane, generally speaking, in dichorionic placentas is thicker compared to monochorionic placentas. Sometimes in low quality machines, even that the membrane in monochorionic twinning is, you know, the sonographer can't see it, and they refer these patients to us as monochorionic monoamniotic. But when we look with more with machines with some sophisticated equipment, we find out that it is a monochorionic diamniotic placenta.
Thank you so much, Dr. Solmas. One more question I have received, I think. Friends, those who want to be a part of the academic group, I have already posted my WhatsApp number here. Please do send me message on the WhatsApp with your name and workplace. I will add you in the academic group. And those I am able to see, so many of my academic group members have also joined. So they all know that how many academic activities we are constantly doing. Please don't post your number here. From here, I'm not able to send me your number and your workplace and name. I will add you from my WhatsApp. So, yeah, Dr. Poonam is having some more questions. Yeah. Just a second. Yeah. There is one question, Dr. Solmas, from, yeah, I'm not able to see. Yeah. That is from Dr. Patel. He is writing, twin-to-twin transfusion syndrome, at how many weeks we can diagnose?
Yeah, actually, it depends on the severity of the condition. Sometimes we get TTTS at
Yeah.
first trimester. One of the very important signs of twin-to-twin transfusion syndrome in first trimester is the discrepancy of nuchal translucency between the two babies. So if you get high nuchal translucency in one baby and the other one NT is lower, although you have to do workup for chromosomal abnormalities, and perhaps you have to do, depending on the amount of the NT, an amniocentesis or CVS or an IPT, you also have to closely monitor this pregnancy every 2 weeks by ultrasound. It is most probably a manifestation of twin-twin transfusion syndrome in the future. But if they manifest early, they are more difficult to treat because they get into stage 3 very soon. And before like 16 to 18 weeks, it is too difficult to do this laser separation of the placentas.
Yeah, thank you. Thank you so much, Dr. Solmas. Just a second, I am checking in the chat box. If there is some more questions, I will take it quickly. Okay, no, I don't think it's relevant. That all you have already covered. So thank you once again for your excellent presentation. So friends, as there are a lot of queries related to this twin pregnancy, I will definitely invite Dr. Solmas once again to take one class on the twin pregnancy. So friends, I hope for all of you are benefited by this excellent presentation. So I hope all of you agree with me this also, that science knows no country. Science is the torch which illuminates the world. So thank you once again. Dr. Solmas is a very, very big name. Is the ambassador of this ICUOG in the North Africa and Middle East countries. So thank you so much, ma'am, for joining with me from the Iran. Madam is from Tehran. So thank you once again from the bottom of my heart. So before I wind up, I want to share some information.
Sure. Actually, I would like also to thank your audience, and for this very, I can see that there is a lot of interest, as you see, in twin pregnancy. I don't know if you have time. If you have like 10 minutes, I can answer some questions briefly. But if you don't, I'm very happy to attend another session about twin pregnancy. So it's up to you. I'm open to questions.
I will just show these 2-3 announcements, and we can take for this twin pregnancy. Just a second.
Okay.
Yeah. Because some doctors are joined late. So friends, those of you are interested for this PCOS, for this tomorrow, as all of you know, the September month is the PCOS awareness month. So the slides are not. So tomorrow at 3 to 4 p.m. I'm having one session on Pcos and nutrition. So all of you are welcome to join for that session. And we started a new online courses for infertility, IVF, aesthetic gynecology, sexual medicine, cosmetology. Soon I will have a word with Dr. Solmas, and we will start on some ultrasound also. But give me some time. So there we are
Okay,
having, and we are having one master class of sexual medicine on 8th and 9th October, which is based on very, very practical scenarios, what you are getting in your daily OPD problems. So what the patients are coming with that. So how we can treat, how we gynecologists can treat that sexual problems. Why to refer every patient to the other specialty. So I tried to cover all that topics in that master class, which we are going to organize on 8th and 9th October. All the registration details and all details are posted in all the social media. Those who are interested can join. Yeah. So now I can take yeah. Yes, Dr. Solmas. Yes, we are happy, eagerly to listen from you regarding the twin pregnancy. Yeah.
Okay, thank you so much. Sorry, I just don't get your voice for a while.
Okay. Just a second. Let me see. Some questions are coming for twin pregnancy.
All right.
Yeah.
Okay, sure.
Yeah. And some doctors want to listen regarding this placental pathologies also. Okay. Yeah. You can see in the question and answer box. Question answer box. Yeah. Hi, Dr. Parvati. Dr. Parvati is writing, in twin pregnancy, mono and dichorionic differentiation at 8 to 9 weeks. She wants some tips on that.
Yes. Yeah, obviously it's easier to identify twin pregnancy at first trimester. Sometimes it's easier in early pregnancy before 8 weeks, but you know, everything depends on the maternal body habitus. And I think if you ask me, the most precise time is at the same time of nuchal scan, because the placentas are well formed and you can see also the babies. And yeah, apart from chorionicity, for example, you can determine if that it is a vanishing twin, if it's a trap syndrome, you know, a cardiac twinning. So the best time is first trimester, between 11 to 13 weeks plus 6 days.
Thank you so much.
Yeah, I can see one other question here. One of your colleagues actually asks, in breech presentation, how can we know the head is flexed or extended? It is possible. You look at the spine. If you look at the position of the, I didn't go through the details about lie, basically. I mostly spoke about presentation. But if you look at if you want to determine the fetal lie, and if the head is flexed or hyperextended, you have to look at the spine and the neck of the baby. It's possible to find out.
Yeah. There is one more question from Dr. Rimjim. Yeah, hi Rimjim. So she is asking about that, how is placental grading done? How important is to grade the placenta?
Great. Placental grading per se doesn't have any prognostic value. So the most important thing is fetal size, amniotic fluid, biometry, differential biometry, I would say, and fetal Dopplers. But placental grading per se doesn't tell you that much about anything. It's just an old definition we all have, you know, just got used to put grade.
Yeah. So now when Dr. Niharika is writing about this abruptio placentae. So I think we will take one separate class for that, the placental pathology and for the twin pregnancy. So
yeah.
I
think there is a question. I can see the last question, which is important. Flicks in amniotic fluid, do they indicate meconium? Again, you know, first of all, you don't know if it is meconium or if it's just flakes of the skin of the baby. So it doesn't have any prognostic value per se, and you need to pay attention if there is a fetal IUGR, if this is small for gestational age, if there are signs of fetal distress, problems in Dopplers. No, the flicks in amniotic fluid doesn't have a prognostic value per se.
Yeah. Thank you so much, ma'am.
You're welcome.
I think with this we will wind up for today. Now again one more question from Dr. Vijay Chauhan. Dr. Vijay, Dr. Solmaz is from more than 1 hour with us. Huh? That again there's a question for the grading of the placenta.
Yeah, stage 1, 0, 1, 2, 3. You know, stage 0 is a placenta which is homogeneous. So it's just like very, very early placentas. Grade 1, you can see some details inside the placenta. It's not that much different. 0 and 1 are mostly the same. Stage 2, you can see some lobules of placenta, but yeah, you can see just the boundaries they have formed. So we call it stage 2. And in stage 3, you can see clear calcifications within the placental actually tissue. An important issue in placenta, actually, this is important because I can see many questions coming up about placenta. The very important point about placenta, which has prognostic value, is identifying placenta accreta. So you see in patients who are at high risk of having placenta accreta, You have to pay attention to placental lakes. If there are numerous and irregular placental lakes, if you put Dopplers and you see big vessels inside the placenta, if you can't identify the Nitabach layer, or this, there's a translucent line between placenta and myometrium. If you can't follow this line, again, if you want to evaluate the placenta and to rule out placenta accreta, you have to scan the whole plate where the placenta has attached to the uterus. So you have to do this sliding movements in parallel lines, along parallel lines and along the whole surface of the placenta. And you look, or you pay particular attention to this translucent line. And if it is interrupted, or it has been replaced by irregular placental lakes, or if you see big vessels when you put Dopplers, you suspect placenta accreta, which as you know, has a very complicated management depending on the stage of pregnancy. This is the most important point about placenta. Sometimes placenta accreta nowadays is not rare, because of increasing number of cesarean sections in the world. But one of the more rare conditions is inflammation in placenta. Placenta has usually a thickness like 1 or 2 centimeters. If you see a very thick placenta, like 5, 6, 7, 8 centimeters thickness, this is sometimes an indicator for some specific type of infections. Again, the mother needs to be referred to a tertiary care center. And many of these cases are associated with intrauterine growth restriction. But it is not grading per se.
Yeah, thank you so much. I will take
You're very welcome.
I will take only last one question, that is from Dr. Asifa Qureshi. She wants to know regarding the ruptured and unruptured ectopic pregnancy ultrasound. The topic of today was the for the 6 steps. Now questions are coming from all the directions, from each and everything.
Okay. Yeah, actually unruptured ectopic pregnancy is a matter of early pregnancy. It's not obviously included in 6-step approach, but the most important thing in an unruptured ectopic pregnancy, obviously you identify this kind, it's a clinical diagnosis mostly. Patients come to you by some abdominal pain, by some retard in their menstrual period. You have got this beta HCG and the titers are not going high enough. The progesterone level might be low. And obviously you look for this ectopic pregnancy. You don't know if it is ruptured or unruptured, but it is mostly with transvaginal approach. This is not my specific area of expertise, to be honest, but I know some colleagues are very, very expert in this field. They visualize the tubes. They look at the whole length of the tube. They look at the ectopic pregnancy. It is not for them, for the experts, it is not too difficult to find out if it is a tubal pregnancy. One of the dilemmas is cornual pregnancy, because in earlier stages, you can't determine if it's ectopic or not. And they usually wait. They get some impression, they wait, and they just follow the pregnancy if it grows inside the uterus or if it grows towards the cornual side, and if it is gonna be a real cornual ectopic pregnancy. Another issue is cervical pregnancy. And this scar type, cesarean scar pregnancy, they are also considered some types of ectopic pregnancy. And it's a whole complete topic. And as I told you, I'm not, my expertise is not in early pregnancy, but it's very important. Yeah, but if I have just 2 minutes, I have a very, very nice memory from my fellowship period. Actually, once I got a pregnant lady for first trimester scan. Okay. So we scanned this lady, she was 12 weeks. We measured nuchal translucency, the anatomy, everything was fine. And we tried to visualize the cervix. I couldn't find the cervix. And I just called my senior doctor. he came and he also couldn't find the cervix. We could see the cervix at some point, but we didn't this alignment of uterine cavity and the cervix. We went and we asked for a consultant to come and look at it. And surprisingly, it was one of the most rare conditions in in this obstetric world. It was obviously, Dr. Ritu, you know what was it? It was a pregnancy in a non-communicating horn.
Yeah.
And actually, only by following this 6-step approach, although at that time there was no 6-step because it was 2007 and this book and the paper was not published, but we were paying attention to these approaches, to this kind of approaches. We couldn't visualize the cervix and we couldn't determine the position of the placenta compared to the cervix. And we picked the case up. And if you don't pick it, it has a very, very high mortality rate. So we were given, some kind of compliment that you saved the woman's life.
Thank you so much. A very interesting case. So before we wind up, Dr. Solmas, besides being such a good doctor, we want to know, what are your other hobbies?
Sorry?
What are your other hobbies besides being such a good doctor? What are your other hobbies?
Yes, all right. Actually, I do calligraphy.
Okay.
I don't know if you know Persian calligraphy. Yeah, if I have the honor of attending one of the other your webinars in the future, I will put the picture of one of my calligraphies. If you are interested.
Great. Of course.
It's kind of Persian art.
Yeah. I know about that. Yeah, very nice.
All right.
So thank you once again, madam. Thank you once again for enlightening all of us. So hope to have you once again soon in one of my upcoming webinars. So thank you once again from the bottom of my heart. In India, here we say, when we end or start, we say namaste. Namaste.
Okay. Thank you so much for your invitation. It was a pleasure. It was my pleasure, really, to attend this webinar. And I'm really looking forward to future collaboration. I hope to invite you to our webinars, our congresses, both in person and online. And I really hope that, I'm really fond of very much of women's health, women's empowerment. And yeah, I'm really looking forward to future collaborations.
So again, this is similarity between us. Likewise, I also am very fond of that. So thank you once again, madam. So in your language, because so many doctors have joined from the Iran also, so I want to say the tashakkur or sefas in your language. Thank you once again, ma'am. Thank you.
I also thank you very much.
Yeah. So bye-bye, friends. See you all soon to again on some next academic hour event. Bye-bye.
Bye-bye. Bye.